Guys, how are you? I hope you're doing fine. Today I'll be discussing a very important topic, which is insomnia. Insomnia. Okay. If a patient is coming to you, how can I help you, doctor? How can I help you? The doctor is asking, well, doctor, I'm having insomnia. So is that a medicine or counseling? It is a medicine station. So today I will be discussing insomnia. Okay? So presenting complaint P1, P2, P3, maftosa. How can I help you? Presenting complaint, doctor, I'm having a problem sleep. B1 is problem or trouble sleeping. Trouble sleeping. That's my P1. Doctor, I'm having a problem in my sleep. I'm having trouble in my sleep. What to do when you have P1? What to do? Always explore. But I'd like, before I start my insomnia, to tell you, a patient who can't sleep, a patient who's having a sleeping problem, when you have a patient who's coming to you complaining of sleep, always explore by saying to him, can you please tell me more about it? Is it that you can't fall asleep? So does that mean that the patient is going to bed at 10 and by the time he or she sleeps, it's 2 after midnight? So is it a problem falling asleep, or is it a problem maintaining a good sleep? So when they sleep, they keep waking up in the middle of the night? Or do you mean that you wake up early? So always explore sleeping as a presenting complaint, guys, please. So can you please tell me more about it? Since when have you had this problem? Since when have you had this problem? When did you start having trouble sleeping? And please tell me, what do you mean exactly by problem sleeping? Is it that you have difficulty falling asleep? So you can't fall asleep easily, difficulty falling asleep? Or is it that you cannot maintain a good sleep? You cannot maintain a good night's sleep? Or is it that you woke up early? So I want to know which one, okay? Then after exploring it, after asking for how long, always ask, just before you had this problem, just before you developed this problem, anything significant happened in your life? Guys, because insomnia, very important cause of insomnia, is a patient who is depressed, a patient who lost one of his family members, a patient who split up with his or her partner. It's always causes of insomnia, okay? So always ask about, just before you had trouble sleeping, just before you start having trouble sleeping, anything significant happened in your life? Very important question, please do ask, okay? So when I explore difficulty in sleeping, the patient gave me long time, 3 months, 4 months, then always psychosocial. Always occupation and social will come early. So always psychosocial. So psychosocial means, what do you do for a living? How is it affecting your job? Who do you live with? How is it affecting the relationship between you and everybody around you? And as well as in psychosocial, how is it affecting your life and your daily activity? So psychosocial. So I explored the insomnia. I asked psychosocial, as it's a chronic problem, and as I told you, very important, just before you started this trouble sleeping, anything significant that happened, because there is a very common station where a patient is depressed, he lost his partner, and that's why he can't sleep, and this is the sleeping problem. That's the cause. Think of it as a sleeping. Someone who can't sleep, maybe he's having a problem in his life. So anyway, after exploring sleeping in details, psychosocial, then I will always, like any station, come to my differentials. So DDs, my differentials. So DDs of insomnia, or causes of insomnia, or differentials for insomnia. always when I come to differential, I will take it in a circle. What do you mean circle, Dr. Mo? This is the bedroom. This is the bedroom. Then, before the patient goes to bed, I will go backward. This is my bedroom. This is my bedroom. Before the patient goes to bed, so before the patient goes to bed, and then that's the evening time, before he goes to bed. Then, before going to bed, which is the midday, and then go back to the morning. So, bedroom, before the bedroom, before the bedroom, which is the midday, and morning. And in between, or in the middle, I will put mental as well as physical. That's it, and we have finished. So, the causes or the differential, whenever I'm having a patient with insomnia, okay? What are the causes? What are the differentials? Bedroom, before the bedroom, which is evening time, before the bedroom, which is midday, before the midday is the morning. Okay. And I will put all the causes of insomnia here. So all the causes of insomnia here. And in the middle, I put two words, mental as well as physical. Mental and physical. All right. So explore the insomnia. And then I started my differentials. Bedroom. What do you mean by bedroom? If the patient is having uncomfortable bed, uncomfortable mattress, lighting, if the light is on in the night time in his bedroom, okay? If the patient is having noisy neighbors in his bedroom, if the weather in the bedroom too cold or too hot for him to sleep, so that's the bedroom, the condition in the bedroom. If the patient is having television in the bedroom, again, computer screen in the bedroom, all this can cause insomnia, all this can cause the patient of difficulty in sleeping. Before the bedroom. So before the patient goes to bed, evening, DESA. What do you mean, Dr. Mo, by DESA? Diet, exercise, smoking, alcohol, plus or minus recreational drugs. What do you mean by that? So before the bedroom, always ask about DESA, diet. So if the patient is having a heavy meal before bed, he will not go to bed easily. He will have trouble sleeping. Exercise. If the patient is exercising before bed, again, he will be hyperactive to go to bed. Smoking. If the patient is smoking before bed, again, he will not be able to sleep easily. Alcohol before bed, again, it will cause him to have insomnia. Plus, recreational drugs. Like what? Like cannabis, like weed. Okay? If the patient is having cannabis, the patient is having weed, again, before bed. Be careful, because under alcohol, I will say alcohol and caffeinated drinks, energy drinks like tea, coffee, alcohol, Monster, Red Bull, energy drinks, caffeinated drinks before bed. So, DESA plus recreational drugs. And when I said DESA, I said in A is alcohol. I said alcohol means anything that you will drink, like alcohol, caffeinated drinks, tea, coffee, all right, energy drinks. And then before bed, which is midday, what will happen in the midday that will cause you to have trouble sleeping, having a nap? So if you sleep during the day, do you think you'll be able to go to bed early? No, you're not gonna be able to go to bed early. So naps during the day. Number two, changing work shifts. So if you are working night time, then day, then night, then day. So changing work patterns. So night shifts can cause, and day shifts, work pattern, it can cause insomnia. Morning, which is basically waking up early in the morning, is one of the causes of insomnia. Waking up early, very early, like 5 o'clock in the morning. If you wake up very early, then that will cause trouble sleeping. So always ask, when about waking up in the morning, it always comes in the sleeping anyway. It always comes with the sleeping. When we ask about sleeping, we always ask, do you mean that you wake up early in the morning? So basically, in the middle of the circle, there is mental and physical. What do you mean by mental and physical? Physical is any physical condition that makes him not having good sleep. Like what, doctor? So mental and physical, yeah? Mental and physical. Let's discuss physical first. But mental is more important. So let's discuss physical first. Physical means head to toe any problem. So any pain anywhere in his body. So if you have any pain in your body, joint pain, any pain anywhere, so that's the physical, yeah? So I said physical plus mental, yeah, in the middle. I will talk first about physical. Any pain anywhere in your body, joint pain, anywhere, any pain anywhere. Headache, any head pain, any head problem, which is headache, okay? So pain anywhere, headache. Come to the chest, any shortness of breath, chest pain, no. Bowel, any diarrhea, maybe he's having diarrhea that's making him pass stool all the time and in the night and he cannot maintain a good sleep. Any urine problem, going to pass urine more often than normal, nocturia, going to pass urine in the middle of the night. So that's all physical. What about mental? Mental is low mood, depression. Low mood and depression always is a cause of insomnia. If the patient is not happy, if the patient is having low mood, if the patient is depressed, do you think they will be able to go to bed? No. So always ask about mood. Always ask about mood. And that will bring me into a very important topic that whenever you have a patient with insomnia, think of NAI. Think that this patient might be abused, for that he is low mood, for that he can't go to bed. So always ask about the mood. Always ask about the mood. Always ask about the mood. So mood is one of the very important causes for insomnia. All right. So now, and always, as I told you, whenever do you want to bring a case of NAI, non-accidental injury, a case of abuse, they always bring it in insomnia. So any patient who's coming with insomnia, think of NAI as a cause. So it's NAI until proven otherwise. So always think of who they live with at home, how is the relationship between you and people at home. Okay, so always think of NAI. Maybe this patient is getting abused. So insomnia, always think of NAI. So always patients, people who are getting abused, they present with insomnia. Okay. Now, how do you manage insomnia? And what are the scenarios for insomnia? Okay, I will tell you something that will be fixed anywhere in management of insomnia. As a structure. This is the insomnia. Explore, differential, and P2, P3, maftosa. Oh, I already asked about them. What do you mean, Dr. Mo? P2, have you had this problem before or any medical condition? P3 is DESA. I've asked already about DESA in this circle. Maftosa, psychosocial is early anyway. So always your stem, your main core of the history is exploring sleeping. Ask the questions that set you to ask. Go for differential, and then the history is done. Okay? The history is done. Psychosocial early. And that's it. And if you think that physical problem has come into P2, DESA here is anyway, P3 covered. So P3 is covered, P2 is covered already in physical problem, psychosocial is outside covered. So now it's insomnia history. So this is now the history for insomnia. Now, when we talk about management as a structure of insomnia, when we talk about management, because I will take now a case by case individually. When I talk about management of insomnia, I will always talk about sleep hygiene in management. Sleep hygiene. In all cases, I will mention sleep hygiene. And what is sleep hygiene? What is sleep hygiene that I will use in managing of most cases of insomnia? So sleep hygiene plus the cause. Let's make it easy. So management of insomnia, sleep hygiene plus the cause. The cause which will be specific to the case. Again. Management of insomnia. How to manage insomnia. I will manage all cases of insomnia through two things. One of them is fixed. which is sleep hygiene, plus managing the cause. So sleep hygiene and the cause, yes. Sleep hygiene and the cause. What do you mean, Dr. Mo? Sleep hygiene, I will give it to you now. That will be everywhere. The cause, depending on the case. When I discuss every case, I will tell you how to manage the cause. So sleep hygiene is basically managing the bedroom. Things that we do in the bedroom and before the bed to have good sleep, to maintain good sleep. Sleep hygiene, okay? So, sleep hygiene is things that you do, things that you don't. Things that you do like what? Like go to bed early. Go to bed early, which means by mean early, don't go to bed late. And wake up every morning at the same time. So go to bed and wake up at the same time every day. 10 till 7, for example. So you must go to bed and wake up at the same time every day. That things that I do, things don't. Do and don't. Do, relax 1 hour before bed. Do relax 1 hour before bed. So for example, take a bath, read a book 1 hour before bed. Because I said, as you know, exercise before bed, alcohol, anything that will make you excited before bed will prevent you from having a good sleep. So go to bed and wake up at the same time every day. An hour before bed, relax, read a book, relax, take a bath. Make sure your bedroom is nice, quiet, cozy, nice atmosphere, not too hot, not too cold, comfortable mattress and pillow. Blind is down so there is no light coming in. Make sure you have eye masks or earplugs if needed. If there is any problem, any noise, or if there's no light coming in, eye masks or earplugs, okay? So this is do. Don't dayset. Don't eat heavy meal before bed. Don't smoke before bed. Don't drink alcohol before bed. Don't do exercise before bed. Don't watch television, computer, use your phone before bed. So do and don't. Do and don't. Do and don't. So sleep hygiene, do and don't fixed everywhere. Plus the cause. The cause, when I discuss every and each station now, I will tell you about the cause. When I discuss every and each station, I will tell you about the cause, how to manage the cause. Okay? And don't forget, in every case of insomnia, DVLA, because this patient cannot drive. So DVLA, because the patient cannot drive. So let's discuss one by one now. The first scenario, you are an FY2 doctor in the GP clinic. Mrs. Ashley Adams, 65, presented to the clinic, diagnosed with rheumatoid arthritis. The patient is on the following medication: methotrexate, 7.5 mg per week, paracetamol, folic acid. Her arthritis is under control. Blood level of methotrexate is normal. Please talk to her, address her concern. What are the positive findings here? Trouble going to bed. Now I will give you the positive in history and management, yeah? Positive in history and how to manage. Every fixed. Sleep hygiene is everywhere, plus the factor. So, positive finding in history, trouble going to bed, started 3 months ago. So ask psychosocial. Husband passed away 6 months ago because of heart attack. Okay? She drinks alcohol before going to bed. Drinks alcohol before going to bed. Drinks alcohol before going to bed. She is retired. She's having past history of arthritis. On examination, everything is normal. Management. So management here, I will pick the point that I will need to work on. The point that I need to work on. Few things here. Few problems here that I need to work on in management. Okay? So, do and don't. As I told you, she mentioned to you that her partner passed away. Her partner passed away before she started having this problem. So, you can refer her to CBT. She mentioned to you that CBT, talking therapy, yeah? CBT, talking therapy. She mentioned that she drinks alcohol, so advise her about not drinking before bed. Okay? That's two main things. Two main things. So, in management, I will talk about sleep hygiene, do and don't, and the cause. The cause is husband passed away before she started having the problem and she's drinking too much alcohol. This is the cause. So, I will tell her, write a list. I will advise her to write a list of her worries, her problem, her worries, okay? And try to find solution, or ideas to solve them, okay? To solve them, all right? So write a list of your worries and any ideas to solve them before going to bed, and this may help you to forget them in the morning. So until the morning, to forget them until the morning. So as I told you, the reasons is there. I will talk to her about her husband who passed away, so we can refer her to talking therapy. Talking therapy. Why? Because she's having a problem here. Ask about her mood, don't forget, yeah? And another reason is drinking alcohol, so too much alcohol. Again, I will address that she should decrease the drinking habit, okay? Now, this patient, plus the factors, I will talk about sleep hygiene, which is do and don't. This patient will ask you for sleeping pills. I will say to her simply, why? Because I've heard about them. So simply, I will say to her that what do you think of addressing the lifestyle modifications first? If it doesn't work, we can think of the pill. Why, doctor? Then talk to her about that risk of the pill, that it's addictive, and we don't really advise with it, and we use it if other non-medical measures doesn't work or don't work, okay? Scenario 2, you are an F1 doctor, 45 years old Alex is having a sleeping problem. He's concerned about it. Okay? So talk to him and this is concerned, okay? What are the positive findings in history? He wakes up in the middle of the night. He wakes up in the morning not refreshed. Headache, okay? He dozes off, okay? His wife noticed that he's snoring, and during the day he's dozing off. So he just like having naps during the day. His wife noticed he's snoring. This patient is a taxi driver. So these are the positive findings. He cannot breathe through his nose. So he wakes up, he sleeps during the night, trying to breathe through his mouth, snoring, wakes up in the morning, not refreshed, naps during the day. Positive. And this comes with insomnia. Examination, very important, BMI. Very important, BMI. This patient, when you take history from him, he drinks alcohol, his diet is not good, he doesn't do exercise, he smokes. So that's the positive finding. So positive symptoms and positive factors, data is all messed up. He doesn't eat good food, he doesn't do exercise, he smokes, he drinks alcohol, okay? So management. I told you management is two things, sleep hygiene plus cause, okay? So on examination, BMI will be high, on examination, BMI will be high. Be careful because the patient will tell you that my wife tells me that I have interrupted sleep, but they don't have a memory for it. So they don't have memory that they have interrupted sleep, okay? So management, senior, investigations, and in the investigations, I will exclude other investigations like full blood count for anemia, vitamins for vitamin level, kidney problem, liver problem, urea electrolyte for hyponatremia investigations, okay? Okay, now this patient will need to be referred to sleep clinic. Why? To assess his sleep at night. So he will need to be referred to sleep clinic so they assess his sleep at night. Okay, what should we do? Sleep hygiene. So I will talk about things that he should do, things that he shouldn't do, which is I spoke about them, do and don't. And I will talk about the DESA. The cause here is DESA. I told you the cause is DESA. So the risk factor is DESA. This patient, it is an obstructive sleep apnea case that causes insomnia. So DESA, diet, exercise, smoking, alcohol. Diet must be eating, he should eat healthy. Exercise, he should do some form of exercise, stop smoking, and decrease the amount of alcohol that he drinks. That's the cause. And the sleep hygiene, do and don't, which is basically as simple as what I said about specific cause. And basically it is insomnia due to obstructive sleep apnea. So it is obstructive sleep apnea case of insomnia. Don't forget DVLA, so don't forget to talk about driving. Referral, sleep clinic for sleep hygiene, to assess his sleep at night, polysomnography. And further, it can be CPAP, continuous positive airway pressure, that's further, okay? or mandible advancement device, but please, you don't need to talk about it. Main concern is addressing data and lifestyle modification, which is basically sleep hygiene. Okay, so always talk about driving. Always talk about driving. This patient should not drive. This patient should inform the DVLA. Okay, next case, you are an FY2 doctor, 32 years old, came with a sleep disturbance and is concerned about it. What are the positive finding? The positive finding: trouble going to bed. He goes to bed late. He wakes up late. He wakes up in the afternoon. So going to bed late and he wakes up late. 3 months ago started. Okay. He will tell you that he smokes cannabis before bed. Cannabis before bed. And he plays video games at night. So the factors are cannabis, which is weed, before bed. Play video games before bed. Started 3 months ago. He goes to bed late. He wakes up late. Examination, everything is fine. Management. So what are the factors here? As I told you, I will follow the same structure in history. I have given you the positive finding, but you will still need to exclude some other findings. The positive is recreational drug, cannabis before bed. Cannabis before bed. These are the positive findings. We'll take history. So how can I help you? Sleeping problem, explore, how long? 3 months, psychosocial, differential, bedroom, before bed. He will give you cannabis history. You can ask about physical and mental, and then go to examination, verbalize, then management. In management, again, cause and sleep hygiene. And the cause and the sleep hygiene, they are similar. So this patient, what are the factors? He smokes cannabis before bed, and he's basically going to bed late. That's why. And he plays video games. So basically, the management here is what we have said. So I will talk to him about things that he should not do, which is cannabis before bed, smoking before bed, alcohol before bed, sleep hygiene. Don't. And do, go to bed early, wake up at the same time. Okay? And if the patient is having an anxiety or stress, CBT. Okay? And play video games, stop playing video games before bed, because it can makes you not able to sleep. So basically it is sleep hygiene management. Okay? Okay. And always I can advise them to maintain a sleeping diary. Maintain a sleeping diary. Okay, so they can have a sleeping diary. All right. Now the patient will ask for sleeping pill. May I ask why? He will give you a reason. Then say to him, we'll start first with that non-medical management, which is basically lifestyle management, which is basically stop smoking before bed, try to stop cannabis before bed, stop watching video games, and then we can look into this if that doesn't work. No, doctor, I want it. Then talk about the risks of it being addictive. All right. Then always safety net for driving. Scenario 4. You are an F1 doctor. Okay, 32 years old, came to the hospital with sleeping problem. Talk to the patient, address her concern. Talk to the patient, address her concern. Okay, so 32 years old, came to the hospital, difficulty in sleeping. Positive finding, trouble sleeping few months back, goes to bed around 2 a.m. after midnight. Sometimes she cannot sleep the whole night. Psychosocial, she's anxious and shaking too much in the station. So in this scenario, she will be anxious. After confidentiality, when you try to make her open, can you please open for me? I'm here to help you. Can you please, I'm here only to help you. So try to open for me so I can help you. Okay, so she will basically, when you offer her support, she will give you positive of that her husband, she had an argument with him and he was violent. So that's the cause. So the cause in this case is NAI, abuse. So this lady is abused. The cause is NAI. Always ask about the mood, her mood will be low. Always ask about the mood, her mood will be low. Always ask about the support system. Very important if a patient is getting abused. Support system. Have you told anyone about it? Do you feel supported? Have you spoken to anyone? Okay, so all about support system. Examine. So what is the cause here? Everything is negative apart from that. Just what is the key question? Just before you had this problem, anything significant happen? then she will show you that she's anxious, she cannot talk, she doesn't want to talk, so please try to let her open. I'm here to help you. Please speak to me. I'm only here to help you. I'm gonna try this to help you. Dr. No offer confidentiality at the end. Everything will be confidential between me and you. And then she will tell you that her husband is violent with her. So what is the presenting complaint? Violent husband. So always explore. Her husband is violent. Since when? Is it the first time? When you said violent, did he physically abuse you? Ask about emotional abuse, okay? Does he call you any bad words or words that you don't like, okay? Anybody else at home, because maybe not only she is abused, but also her father, her mother, a child. So anybody else at home, who lives at home as well, anybody else at home, okay? How's the relationship between your boyfriend or your husband and everybody else at home? So maybe not only her getting abused, but also everybody else is getting abused. So always explore who is at home, okay? Then this is the cause, the violence. The violence is the cause. Now, what is the management? What is the management if she is getting abused? What is the management? Okay, if there is no children, if it's only her and getting abused, she's got mental capacity, which means she understands what's happening. Can you force admission? No. Can you force social service? No. However, you can advise her. You can advise her. You can try to help her. You can try to support her. Offer her support. So basically, you can say to her, well, nobody has the right to abuse you. Nobody has the right to be violent with you. We have all the help and support that we can offer for you. So basically, if she's having a problem, for example, with her accommodation or shelter, you can offer her that we can arrange this for you. We can discuss it with social services who can take this over, okay? What if she's refusing? It's fine if she is refusing, you cannot force admission on her. So if she is refusing, you cannot force admission on her, okay? So we can refer her to an organization called Multi-Agency Risk Assessment, okay? Which will support her, provide her with things like shelter, like everything, okay? And support system, they will give her support system. However, if she is refusing and if she's insisting that she wants to go home, she can go home. She can go home. She's adult. The only case that you can keep it and you can inform social services and you keep by force under the Mental Health Act is two things. Very, very old, very, very young. So very, very old patient or very, very young patient, child, you can keep them because they are vulnerable. They cannot defend themselves. But she is 32, you can only advise her. You can only talk to her about the support system. You can only ask her about any emergency plan. If things goes wrong, do you have any emergency plan? Okay, do you have anybody that you will go back to and you will ring and you will contact? You can only offer support, but you cannot force it, okay? And you can advise her to ring the police if things goes wrong, okay? So this is in terms of, again, NAI as a cause of insomnia. So she's coming with insomnia, but the cause is NAI. There is another scenario, 45 years old female presented to the hospital, to the GP clinic with insomnia. So how can I help you, doctor? I have difficulty in sleeping. That's another scenario. How can I help you, doctor? I have difficulty in sleeping. So when you explore, how did it start? When you say difficulty in sleeping, does that mean that falling asleep is the problem, or maintaining a good sleep is the problem, or waking up early in the morning? Anyway, she will tell you, doctor, I cannot go to bed early. Psycho for how long? 2 months. Psychosocial, when you go for differential, but before differential, the most important question, just before you had this problem, anything significant happened? She will tell you, my husband passed away. This is the cause. My husband passed away. That's why she cannot go to bed early. She cannot sleep properly. So always go for few differential, bedroom before bed quickly. Then you will go to the mood. Very important. So that's mental trauma. So ask about the mood. She will be low mood. In this case, if she is low mood, then in management, you can refer her to psychiatrist for talking therapy, okay? You can always, if she is low mood, you can always assess her suicidal thoughts. That have you ever tried to harm yourself or harm others? No. And then in management, you will talk about psychiatrist referral for talking therapy, and if that doesn't work, we can basically give you antidepressant, okay? So that's the management. So it's psychiatric kind of case because the patient is having low mood, the patient is upset because of her husband. So her husband passed away, that's why she cannot sleep. So the management is basically talking therapy, okay? That's it. And if that talking therapy doesn't work, then we can refer you to psychiatry. We can give you antidepressant medication. So the station will be referred to psychiatry for talking therapy. If it doesn't work, antidepressants, all right? So that was the last case for insomnia. Thank you very much.